Croup and epiglottitis are two pediatric respiratory conditions that share similar symptoms but require distinct management strategies. For those who are preparing for the board exam, understanding the differences between these conditions is critical. Croup is a viral infection that typically presents with a barking cough and inspiratory stridor, while epiglottitis is a bacterial infection characterized by sudden onset fever, drooling, and severe respiratory distress. Since misdiagnosing these conditions can lead to inappropriate interventions and severe complications, mastering their identification and treatment is essential for safe and effective patient care. First, let's talk about croup, or laryngotracheobronchitis. Croup is a viral infection that causes inflammation and swelling of the larynx, trachea, and bronchi. The parainfluenza virus is the most common culprit, though other viruses like influenza and RSV can also be responsible. The swelling leads to airway narrowing, particularly in the subglottic region, causing the characteristic barking cough and inspiratory stridor. Symptoms usually develop gradually over a few days, often worsening at night. And then we have epiglottitis. Epiglottitis is a bacterial infection that leads to rapid inflammation of the epiglottis, the flap of tissue that covers the trachea during swallowing. The most common causative agent is Haemophilus influenza type B, though Streptococcus and Staphylococcus species can also be responsible. Unlike croup, epiglottitis progresses quickly and can lead to complete airway obstruction within hours if not promptly treated. Now let's dive deeper into the clinical presentation to learn more about the key differences in symptoms between croup and epiglottitis. First, we'll talk about croup. Croup has a gradual onset, typically over a few days. It's most common in children 6 months to 3 years of age, and they often have a low-grade fever that rarely exceeds 102 degrees Fahrenheit. It's easy to distinguish croup because it causes a characteristic barking or seal-like cough. It also results in stridor that can worsen with agitation or crying. Croup usually does not cause drooling, but it does cause a hoarse voice and often a weak cry. And for positioning, the patient can lie flat and their symptoms will often improve with cool air or humidity. Epiglottitis is different because it has a sudden onset with rapid progression over a few hours. It typically affects children 2 to 6 years old, but can occur in adults. Epiglottitis causes a high fever that is often greater than 102 degrees Fahrenheit. Coughing and stridor is not common in patients with epiglottitis due to severe airway obstruction. It often causes drooling due to the inability to swallow. Another sign to look for is a muffled voice in these patients. And when it comes to positioning, the tripod position can help to improve breathing, which involves the patient leaning forward with their hands supporting the body. And now let's talk about the diagnosis. Both conditions require careful assessment to avoid misdiagnosis, and the board exam often includes questions that test your ability to differentiate between these two conditions based on diagnostic findings. Croup is usually diagnosed clinically based on symptoms, meaning no invasive testing is typically needed. If imaging is performed, a neck X-ray in the AP view may show the classic steeple sign, which is caused by subglottic narrowing of the airway. Pulse oximetry readings are usually normal unless the case is severe. Overall, diagnosis for croup is primarily based on observation and patient presentation. Epiglottitis, on the other hand, often requires more careful diagnostic steps due to the risk of airway obstruction. A lateral neck X-ray can show the characteristic thumb sign, which indicates a swollen and enlarged epiglottis. If airway visualization is necessary, a laryngoscopy may reveal a cherry red or swollen epiglottis, but this should only be done in a controlled setting with emergency equipment on standby. Blood cultures are often obtained to identify the bacterial pathogen responsible. And it's important to remember that in a suspected case of epiglottitis, you should never attempt to examine the throat with a tongue depressor, as this could trigger complete airway obstruction. But now let's talk about treatment and management. Once croup or epiglottitis is diagnosed, immediate and appropriate treatment is crucial. Because croup is caused by a virus, treatment focuses on managing symptoms and reducing airway inflammation. Most cases are mild and can be treated at home with supportive care. This includes using humidified air, such as cool mist or steam, to soothe the airway, keeping the child well hydrated, and using antipyretics like acetaminophen to reduce fever. However, in moderate to severe cases, additional interventions may be necessary. Nebulized racemic epinephrine is often used to reduce airway swelling and improve stridor, while corticosteroids are often given to decrease inflammation. Oxygen therapy may be required if there is evidence of hypoxemia. In more serious situations where the child shows signs of respiratory distress, hospitalization is recommended for close monitoring and treatment. Epiglottitis is considered a true medical emergency due to the high risk of sudden airway obstruction. The first and most urgent priority is securing the airway before respiratory failure can occur. In a controlled setting, endotracheal intubation is typically performed to ensure the airway remains open. If intubation cannot be achieved, an emergency tracheostomy may be needed. Humidified oxygen is administered if the patient shows signs of hypoxemia, and IV antibiotics are started immediately to combat the bacterial infection. Because these patients often have difficulty swallowing, IV fluids are used to maintain hydration. Close monitoring in the ICU is essential, as the condition can deteriorate rapidly and may require further emergency intervention. In a suspected epiglottitis case, never delay airway intervention to obtain an X-ray. If severe respiratory distress is present, immediate intubation is the priority before testing. And now let's get into some tips to help you prepare for the board exam, which this section will also serve as a recap for some of the stuff we've already covered. But as you know, the exam may test your ability to recognize key clinical signs, diagnostic findings, and initial treatments. It may also present you with a case scenario where you must make the correct clinical decisions. Some key concepts that often appear on the exam include recognizing the steeple sign in croup versus the thumb sign in epiglottitis on X-rays, identifying the appropriate treatment, such as steroids and nebulized epinephrine for croup, and immediate intubation and antibiotics for epiglottitis. Understanding the urgency of airway intervention in epiglottitis, and avoiding critical mistakes such as using a tongue depressor in patients with suspected epiglottitis. And now for some more exam tips. The most reliable way to distinguish croup from epiglottitis is by analyzing their symptoms. Croup presents with a barking cough, inspiratory stridor, a low-grade fever, hoarseness, and a gradual onset. In contrast, epiglottitis is marked by sudden appearance of a high fever, drooling, muffled voice, and the absence of a cough. Children with epiglottitis often assume a tripod position, sitting forward with their hands propped on their knees to help them breathe. A helpful exam hint to remember is this: if a child is drooling, sitting upright in distress, and struggling to breathe without coughing, epiglottitis should be suspected, and immediate airway intervention is crucial. Radiographic findings can further help differentiate between the two. Croup typically shows a steeple sign on an AP neck X-ray, which reflects subglottic airway narrowing. On the other hand, epiglottitis reveals the thumb sign on a lateral neck X-ray, indicating a swollen epiglottis. However, here's a key exam tip. If epiglottitis is suspected, securing the airway must always come before imaging. Never choose X-ray as the first step in the diagnostic process for epiglottitis. Croup treatment focuses on reducing airway inflammation and includes racemic epinephrine, corticosteroids, and humidified oxygen. Epiglottitis, however, demands immediate action to protect the airway. The first step is controlled endotracheal intubation. If intubation is not successful, an emergency tracheostomy may be required. Once the airway is secured, IV antibiotics are administered along with humidified oxygen. For the exam, remember to never choose nebulized epinephrine or steroids as the first treatment for epiglottitis, as these do not address the urgent need for airway management. There are several critical mistakes to avoid when managing these conditions. As previously mentioned, never attempt to examine the throat with a tongue depressor because it could lead to complete airway obstruction. Additionally, airway management should never be delayed for diagnostic testing. If a child is showing signs of distress, always intubate first. For croup, remember that it's a viral disease, so antibiotics are not appropriate. And one final exam tip is that if the question offers immediate intubation as an option for epiglottitis, it is likely the correct answer. When assessing a child for suspected croup, begin with a detailed history and physical examination, pulse oximetry, and if necessary, an AP neck x-ray to look for the steeple sign. For epiglottitis, you can also start with a history and physical, and also check their oxygen saturation. However, do not attempt a throat exam with a tongue depressor. The airway must be secured before any additional diagnostic procedures are considered. In moderate to severe cases of croup, the focus is on supportive care with oxygen therapy, nebulized racemic epinephrine, and corticosteroids. The child should be monitored for improvement, and intubation is only considered if the condition worsens. With epiglottitis, airway security is non-negotiable. The first step is controlled endotracheal intubation, and if that fails, an emergency tracheostomy must be performed. Once the airway is secure, IV antibiotics can be started to treat the underlying infection. For worsening croup, if symptoms persist after racemic epinephrine or if stridor continues to worsen despite treatment, ICU admission and possibly intubation may be necessary. In epiglottitis, any signs of complete airway obstruction call for an emergency tracheostomy if intubation is not successful. These patients should always be transferred to the ICU for close and continuous monitoring. In managing croup, avoid prescribing antibiotics and refrain from intubating unless the child is in severe respiratory distress. For epiglottitis, never delay airway intervention for the sake of testing and do not attempt to visualize the airway with a tongue depressor. Also, never leave the child lying flat. Instead, allow them to remain in a comfortable, upright position to ease breathing. The bottom line is that croup is typically managed with racemic epinephrine, corticosteroids, and supportive care measures. Epiglottitis, however, requires urgent airway management followed by IV antibiotics. In any suspected case of epiglottitis, securing the airway must always come before ordering additional tests or treatments. But as you can see, mastering the differences between croup and epiglottitis is essential. While both conditions involve upper airway obstruction, their causes, progression, and treatment strategies are dramatically different. By understanding these key differences, you can ensure not only exam success, but also life-saving interventions in clinical practice as a respiratory therapist. For more exam preparation tips and resources, be sure to utilize our materials, which includes everything you need to earn a passing score. I'll drop links below down in the description. And please let me know which topics you would like for us to cover in our next video. Have a nice day, and thanks for watching.